Assalamualaikum. How are you? Can you people hear me well? Assalamualaikum and good morning, everybody. Wake up, funny year. Wow. Thanks for the wish, Muzammil. How are you people and how did your result go? I hope all of you did well, got a very good result. And my sympathies for those who could not do very well, but be sure professors are there. They wanted to meet you again, so don't worry. Allah be with you. Inshallah, you'll do it this time. So this is your last year now, last professional, that is, I must say, the last year of your student life. So enjoy it, do whatever you can. And that's what I mean study-wise, to prove yourself, because you'll have to study each and every minute after your graduation, but not with the same status. Your status will definitely change, inshallah, next year, but you will miss these student life years. So do whatever you can to make it more memorable and to make it even a very good phase of your life. So let's start with today's topic. Today's topic is eczema. I hope many of you must have heard this word. So what comes in your mind when you hear or read the word eczema? Anybody? What is meant by eczema? Any idea? Any guess? Yes? I can't hear anybody. Well, rash and itch. Definitely there is rash and also there is itch. So what do you understand with the word eczema? So I hope at the end of this lecture, you'll be able to identify a patient of eczema. Yes, Shahram, this may be caused by autoimmunity, but not always. So this is one of the reasons. Good, good. So you'll be able to identify a patient of eczema, and definitely you will know what to do and how to deal with the patient. You see, eczema, it's a very commonly used word, very commonly used term. People and patients who come to us, they use it alternatively with dermatitis. They say, I'm having some kind of dermatitis. Well, dermatitis, as the name suggests, dermatitis, it's inflammation of the skin. So we can say that all the eczemas may be dermatitis, but not all the dermatitis may be eczemas. So I give you a brief outline of what an eczema exactly is. Eczema, it's a term derived from Greek word that is ixia, which means to boil. It is a clinical and histological pattern of inflammation of skin that is seen in a variety of dermatosis with widely diverse etiologies. So there are so many reasons why do anybody get eczema. Okay? It's a variety of dermatosis, basically. And we can classify it on different basis like It can be on the basis of morphology, that what types of patterns are produced. Then it can be on the basis of etiology. It can be on the basis of duration. And we discuss them briefly one by one. So on the basis of duration, you can simply say acute eczema, subacute eczema, or chronic eczema. The cutoff value here is 6 weeks almost. So if it's less than 6 weeks, then it's acute eczema. And if it's more than that, then it falls in the category of chronic, or sometimes we say subacute eczema according to the clinical condition. Then on etiological basis, we can again classify depending upon the cause. Etiology, as the name suggests, depending upon the cause, whether the cause is from within or it's from the external environment. So if it is from external, because of reasons in the external environment, then we call it exogenous eczema. And when it's from within, then it's endogenous. In exogenous eczema, we can have irritant eczema, we can have allergic contact dermatitis, then we can have photoallergic contact dermatitis. You see, it's depending upon the etiology. Be it an allergen, then it's allergic eczema. If it's an irritant, it's an irritant contact dermatitis. If it's because of sunlight, then it's photoallergic contact dermatitis. And a different form is eczematous polymorphic light eruption. It could be infective eczema because of some infections occurring elsewhere in the body, leading to symptoms and signs of eczema. Then it could be dermatophytide, that is because of some fungal infection occurring somewhere else in the body and producing eczema-like reactions. And then it could be post-traumatic eczema. These are the types of exogenous eczema, and among the endogenous eczema, the most common, the most important, most widely seen, and very prevalent, even in our setup, is atopic dermatitis or atopic eczema, which we'll be discussing separately. Then we can have seborrheic dermatitis or seborrheic eczema, steatotic eczema, discoid eczema, and so many other types which we will briefly touch. Now, this was regarding the classification. Then about the clinical features, what do we see? As you told me that you see, mainly the main reason is dryness. Skin is dry because of one reason or another, it's dry. Now, dryness leads to itching. Itching leads to redness or erythema. There might be vesicle formation in very acute and very severe causes like allergens or contact dermatitis because of irritants that can lead to vesiculation. With vesiculation, there will be exudation of fluid, which upon drying produces crusting. Then when there is itching, there may be excoriation marks, linear or otherwise patterned because of scratching. And if it becomes deeper, that can lead to fissuring. There may be, in chronic cases, papulation, that is papule formation upon dryness, or when it becomes chronic, there may even be scaling and lichenification. Lichenification is when there are typical patterns seen on skin. Skin becomes harder, drier, and thickened because of chronic scratching and this chronic inflammatory changes. So simple clinical features mean is there is dryness that leads to itching. Itching causes redness or erythema. Then there may be, in acute cases, vesiculation. Vesiculation leads to exudation of fluid, which upon drying can cause crusting. Then there may be excoriation marks, which when become deep can produce fissuring. There may even be papulation, scaling, or lichenification. Now we'll briefly discuss each and every type separately. First, beginning with those types that are because of duration. In acute, you will see that the condition is always fresh. That is, there is exudation, there may be vesiculation, the skin is red, dry, and all these changes can be seen as you can see in the picture. So this is acute eczema. Then in subacute, acute changes have subsided, and now the skin is reddened. There is erythema, there may be dryness, flaky skin is there, irritated skin. You might see excoriation marks. And in chronic eczema, typical dried, thickened, hardened with pattern type of patterned skin is seen. That's known as lichenification over here. This is when the patient or when the case has become chronic. Now we'll discuss these changes, these different types, as I told you. Those conditions that are more prevalent and more relevant to your setup. We'll discuss them one by one briefly and separately. First and foremost is seborrheic dermatitis, as the name suggests, because of seborrhea, and it's mostly on those cases where there are abundant sebaceous glands like the face, the scalp, and upper trunk. And mostly it is because of dandruff, the flaky white things in the scalp. These are basically fungal in origin, and they are also linked to increased sebaceous activity seen in these patients. And here you can see red, sharply marginated lesions, which are covered with greasy scales, greasy because of increased sebaceous activity. As I told you, these are seen mostly in those areas where there are sebaceous glands in abundance. These are on the scalp, on the face. It may be around the eyebrows, especially in the nasolabial folds, and mustaches or beards in case of males. And usually there might be a positive family history that people are affected in similar setup. Like if someone is having dandruff, that can be contagious with comb carried to the other patient and can lead to this condition. And even stress may increase the symptoms. How stress can increase the symptoms of sebaceous or seborrheic dermatitis? Anybody, can you suggest anything? Yes? How stress can increase seborrheic dermatitis? Anybody who's awake? How stress can increase the symptoms of seborrheic dermatitis? Yes, due to frustration. That's what I'm asking. How stress can increase seborrheic dermatitis? Yes, yes, yes. Androgens increase and increase the activity of sebaceous glands. Good, Muhammad Muzammil. Great. So androgen hormone levels increase in stress and they increase the sebaceous activity that leads to an increase in seborrheic dermatitis. If someone writes the history, they must write that there was a phase in COVID when senior teachers were teaching and the nation was sleeping. My goodness, I wonder, and I really wonder what you're gonna do. You are sleeping all the time during the classes, and how are you going to cover these things? My dear, not everything is given in the books. Feeling sorry for you and even more for myself that I prepared this lecture in so many days, almost take a whole week. And look at you people, you are just sleeping like that. So as I told you that these lesions, they are more in nasolabial folds, mustache and beard area, and here around the ears as well, more so in the hairline. Also seen on the trunk, in the flexures. And how do you treat them? Okay, okay, it's all right, but at least you can give a gesture that you people are there, and I'm not just talking to the screen. Thanks for the response, Nishan. Okay. And how do we treat seborrheic dermatitis? As I told you, the main reason is the fungus, Malassezia furfur. So we give medicated shampoos, that is those containing antifungals. Then to reduce the inflammation, we can also give topical steroids. Even topical antifungals can be applied on the body and face. And if there is secondary infection, topical and oral antibiotics, even oral antifungals and steroids can be given. And of course, if there is any itching, you can give antihistamines. Then we have asteatotic eczema. Asteatotic eczema is also known as anhydrotic eczema or eczema craquelle. As the name suggests, anhydrotic. This is because of extreme dryness. Anhydrotic and eczema craquelle because it leads to crack formation, as you can see in the picture. And it develops in elderly usually, and especially in winter when there is extremely dry skin, and usually it's on the hands, legs, and arms. Now, in elderly, as a person ages, there is usually a decline in the sebaceous gland activity. Again, I would like to ask how? How in elderly the sebaceous activity is decreased? All right. In elderly, there is decrease in hydration. There is decrease in sebaceous activity because of decrease or loss of the androgens. And as there is age, there is atrophy of the sebaceous glands as well. So all these things, they lead to a dry skin. Then there may be other reasons like person is having diabetes, or in old age they're taking drugs like diuretics, or they may be because of malnutrition or malabsorption, nutrient deficiency like zinc deficiency, or there are other drugs like statins that lead to decreased lipid. So all these conditions can lead to dryness in elderly people. There is a decrease in the surface lipid, and that leads to extreme dryness, which becomes even further aggravated in winter months. That leads to this condition in which the skin becomes dry, scaly, and there may be even fissures that form, and that may become hemorrhagic even upon scratching. So this is asteatotic anhydrotic eczema or eczema craquelle. Then the treatment is environment adjustment, like in winter, if they're using heaters, there must be something to increase the humidity in the room, like a bowl of water or something like that. Then bath oils or emollients, moisturizers can be used. And they must avoid excessive use of soap and washing to prevent it from even more drying. Then another condition is venous eczema. This is seen in those patients who are having venous hypertension that leads to stasis in the lower parts of the legs, especially. And when there is exudation because of this stasis that leads to edema, there is exudation, and that involves the lower legs and ankle area. There is irritation, itching, and that lead to even a formation of ulcers. These are known as venous ulcers. So what do you see on clinical examination in these patients? We can see varicose veins, there is edema, sometimes even there may be purpura or hemosiderosis. In extreme conditions, when the patient uses to scratch excessively, there may be ulcer formation. Then another condition is discoid eczema. Discoid, as the condition the name suggests, is disc-like. It's also known as nummular eczema. Nummus means points. So nummular eczema or discoid eczema. These are actually circular or oval plaques of eczema with clearly demarcated edges, and these are seen on different parts of the body. They may be, and the reason may be environmental, physical, or chemical trauma, or there may be sensitivity to some cream applied or even to gold. So there are disc-like lesions that are scattered all over the body. These are dry, and these may even become aggravated in winter. Here you can see different disc-like or coin-like lesions. Plaques are seen when they coalesce. So this is discoid eczema, which is, as the name suggests, disc-like or nummular eczema that is coin-like. Again, skin hydration, excessive use of emollients and moisturizers. Even in severe cases, you will have to apply some sort of topical steroids to control the inflammation. If there is secondary infection, antibiotics, then again, sometimes we have to give phototherapy in the form of ultraviolet B type light. Then another form is eyelid eczema. As the name suggests, the eczema is usually confined to the eyelid area. It is maybe because of atopic dermatitis. It may be because of seborrheic dermatitis, because seborrheic areas, they are very near to the eyelids. And it may even be because of some sort of contact dermatitis, like with some cosmetics or some other thing that is coming into contact with your face and especially irritating the eyelids. Again, the treatment is removal of the cause, correction of the basic defect, and that may be done with the aid of topical steroids or immunosuppressants. Then another very important type is hand eczema. There's so many patients, and especially females, that come to our OPD and they are having chronic itchy lesions that are exudative, and they are remitting and relapsing, coming and going, waxing and waning, improving, and then again deteriorating. And they say that it has been there for so many years. So this is very common hand eczema. In this case, the dermatitis or the eczema is confined largely to hands, but there may be involvement of other areas. Like this, in this case, they come with eczema of the hands along with feet. There may be involvement of the wrists or the parts, and usually it may be the back of hands, but palms may also be involved. So upon examination, you see there is dry, itchy skin. There may be blisters in acute forms or scaling and cracking in extreme conditions when it has become dried. Here you can see in acute form, there may be exudation, there may be blister formation, acute hand eczema on the dorsum of the hand, and you can see that the skin is thickened. In chronic conditions, it becomes thickened and lichenified. That is, the skin markings become prominent. Another type of hand eczema is when there are small sago-like blisters, and usually many of you must have experienced along the lines of the sides of your fingers, and even it may be present on the soles. And these are very tiny, tight, intense blisters that are extremely itchy. And if you somehow manage to break them, there is exudation of simple fluid. They may become larger when they coalesce, and these, if you do not break them, they dry up in 2 weeks, up to 2 weeks. And usually in these cases, you can see even nail changes. There are pitting, and surprisingly, these are seen more in warm weather. So this is palm legs, another type of hand eczema in which you see tiny, tight, tense vesicles along the sides of your fingers. They may even be on the palms, soles, and these are usually seen in warm weather. And if you do not break, they may dry up on their own in, say, up to 2 weeks, and they are extremely itchy. Here you can see crops of clear vesicles that are seen in the palm. These are usually deep, so it's not easy to break them. And these are, you can see, sago-like. Then another type of very common condition, that is pityriasis alba. Pityriasis alba pertaining to white. And this is a very common condition that is seen in children to young adults of 3 to 16 years of age. They're round, oval, or irregular, hypopigmented, areas. These are usually seen on the face. They're more prominent over there from where they're noted. And people usually think that this is because of calcium deficiency. No, this is not so. This is a type of eczema. There is usually scaling on it, and they may also be seen on other parts like trunk, and you can very easily diagnose them by seeing the age and the scaling upon them. And the simple treatment is giving emollients. Usually Vaseline is enough, and some people who prescribe steroids and patient continues taking these steroids, that leads to atrophy and other side effects of local application of steroids. And we can also give steroid sparing agents like tacrolimus and pimecrolimus that does not have the side effect of causing atrophy like steroids do. Here you can see these are white, hypopigmented, oval to rounded lesions seen mostly on face. So this is not because of any calcium deficiency or so. This is the type of eczema, and simple you can with simple application of emollients like Vaseline, it can go away in some time. Then another condition is infective. You must know the difference between infective and infected. Now, if there is an eczema due to any reason and it becomes secondarily infected, say with bacteria or fungi, like in this case, there is impetigo-like changes. So this is known as infected. When there is eczema that becomes secondarily infected, then it is known as infected. And if the eczema is because of some infection that is occurring on the body somewhere else, for example, it could be a fungal infection or a bacterial infection, and because of the byproducts or the because of the byproducts or the microorganisms themselves, they cause some kind of immune sensitization in the body that leads to itching at some place that is far away from the original lesion. This is known as infective eczema. And the simple treatment is to treat the original infection. That is, if it's a bacterial infection, we give antibiotics or antifungals. And upon treatment of the original lesion or original cause, the eczema itself subsides automatically. So this is infective eczema. Then in general, how do we treat the eczemas? Simple thing is to treat the cause, to eliminate the predisposing factor, whatever it is. Like we discussed in so many conditions, be it seborrhea, be it dryness, be it irritants or allergens and whatever, you have to eliminate the predisposing factor. Because I always tell the patients that these eczemas, these are type of allergies. Allergies can never be corrected. We just treat them once they occur, and forever we have to prevent them from occurring. That is, we have to keep away from those things that cause them. There may be irritants, there may be allergens, there may be seborrhea, that may be dryness, or any other thing that may be infection. In case of infective eczema, we have to eliminate the cause. Then symptomatic cover, that is in the form of antihistamines, rest, and sometimes even sedation is required, because in cases of extreme itching, the patient cannot sleep at night. So we have to keep them cool and calm, give some sedation, especially in elderly. Then we have to apply plenty of emollients in any case, even if it's not because of dryness, but emollients help a lot. Plus, we cannot give them steroids all the time. So many times we can give them emollients to apply forever. And in between, whenever they get an acute or chronic situation, they can use topical steroids or steroid-sparing agents like tacrolimus, pimecrolimus. In some cases, we have to give them wet dressings and soaks and things like that. So the take-home message in case of eczemas is you have to prevent them from occurring and reoccurring, because they will not be corrected or treated forever. You can treat an acute condition by symptomatic care. You can give a topical or other systemic antibiotics if there is any infection. We can give even steroids up to some extent for a few days, and we can even dilute the steroids with Vaseline or the emollients. But for good, they will have to use these emollients and to keep away, like in case of hand eczema, mostly this is because of detergents or soaps that are being used. So they should use gloves that are available in the market for washing and dishing. Now we will discuss one of the most important types of eczema, very common and very important from even this your academic point of view. This is atopic eczema. Atopic eczema or atopic dermatitis. This is an itchy, chronic or chronically relapsing inflammatory skin condition. It's itchy, it's chronic or even chronically relapsing itchy skin condition that occurs in many patients, and it usually starts in childhood, usually before 2 years of age. That is, whenever it's there, it manifests even in infancy, begins in infancy. However, in some patients, it may occur or manifest itself a bit late, but usually it's less than 2 years. It is characterized by, again, itchy, dry condition skin. There is erythema. There may be formation of papules or papular vesicles in chronic conditions, which may become excoriated upon scratching and then lichenified. And usually in adults, as we'll be discussing, they usually have a flexural distribution. Now, what is the reason for this atopic dermatitis? There are two factors that are hereditary or genetic factors, and then there may be environmental factors. In genetic factors, there is usually mutation in filaggrin gene. Now, this filaggrin, this is a part of the skin that forms an effective barrier. So because of mutation in this gene, there is a lack of effective barrier that leads to increased transepidermal water loss and again resulting in extreme dryness. So this is the main genetic factor that was responsible in atopic dermatitis. That is, there is mutation in filaggrin that was responsible for maintaining a good barrier, physiological barrier that maintains humidity and hydration in the skin. So when this barrier is missing, there is increased transepidermal water loss. And then again, the environmental factors like pollutants and microbes that play their role, and together these manifest in the form of a dermatitis that is known as atopic dermatitis. Now, as I told you that usually the age of onset is even before 2 years, but it may occur at the level of 2 to 6 months of age. So the distribution of the lesions that depends upon age. So we divide them into different phases. That is an infantile eczema, then we have a childhood eczema, and then the adult phase. And then a typical part is hand eczema, that is atopic hand eczema. That is not different from that eczema that we just discussed in hand eczema, but in this case, it is more prevalent. That is atopic hand eczema is, or hand eczema is more prevalent in case of atopics. In infantile atopic dermatitis, as I told you, that usually in 60% of cases they present soon after 2 months, that is even before 6 months of age, and it begins from the cheeks. So if you see very young children, infants who have these very reddish cheeks, you can diagnose it if you confirm other things as well. That is, there is a positive family history. There is generalized dryness on other parts of the skin as well, and they're itching all the time, and especially it's more on the cheeks. However, it can also involve other parts like scalp, neck, forehead, wrist, and extensors. And if there is a large part of the body involved, it may also lead to erythroderma, that is generalized redness of the skin. And surprisingly, the buttocks and diaper areas are spared. Here you can see acute condition, acute eczema. It's involving the cheeks, the face, the scalp, and the distribution is such in case of infantile phase. Then in childhood atopic dermatitis, it is characterized by less acute lesion, and mostly the flexures are involved. In case of infantile phase, there was extensor involvement more, but in case of childhood and adult type, it's more flexure involvement, that is antecubital and the popliteal fossa, the flexure raised, even the eyelids and face may be involved in these conditions. And if there is extensive involvement of the body, say more than 50% of the body surface area is involved, then there may be associated growth retardation in these children. Then again, in adult atopic dermatitis, the distribution remains more or less the same like it was in case of childhood. That is, again, the flexures are involved, the antecubital and the popliteal fossa, and the front side of the neck. And there is typical look of the neck that is because of continuous scratching and dryness, and we call it dirty neck. And even the areas on the forehead or around the eyes may be involved. And these individuals, that is the adult atopics, they are more at risk of developing hand dermatitis than the rest of the normal people. And almost 70% of these patients may have hand dermatitis sometimes in their life. And especially, as I told you, it's more common in women because of use of detergents and soaps that they use in household chores. Here you can see it's hand eczema. There is involvement of the eyelids, face, and forehead. Here, hand eczema, and this is involvement of the feet. Again, chronic changes and a dirty neck, that is because of chronic scratching, can lead to this picture. With atopics, because they are affected since early childhood, even infancy, there is a positive family history. There are other allergies also present like rhinitis, and common cold is very common in these patients. So because of this chronic, and this does not correct because there is a genetic defect in there. So they have to take good care of their skin, keep it hydrated and moisturized. And if they fail to do so, they are again presenting to the OPD again and again. And because they can affect their sleep, because of chronic itching, they can be socially stigmatized. So these are having psychosocial aspects of the disease as well. And as I told you, if it's involved, if it has involved more than 50% of the body surface area, then it can lead to growth retardation because of the disease itself and because of the excessive usage of steroids for the treatment. Then there may be secondary bacterial infections, excessive viral infections, and there are certain ocular changes in these patients, that is early involvement of the lens that leads to cataract. There may be keratoconus. There is a fold underneath the eyes, typical that we check upon a clinical examination, and there are other complications as well. Usually the diagnosis is clinical. Upon upon taking history, we can ask for family history. Usually there are one or two siblings or parents that are having the same condition or any other allergic condition like rhinitis. There may be a common cold, and even there may be history of asthma and first degree relatives in the family. So we do not go for any extensive investigations, but upon asking for complete blood picture, there is usually eosinophilia, and usually total serum IgE levels are increased. If there is any suspicion or any other reason, we can go for a biopsy and send it for histopathology. And how do we treat? Again, because this is a lifelong condition, especially in atopics, we can tell them that your body is genetically dried. That is, it's drier than anybody else around you. So you have to keep away from irritants. Like we should suggest some soap substitutes. We tell them to use less soap, And do not go for excessive bathing and washing. Then reduce exposure to allergens. Then we can give or suggest different emollients that they can use before and after a bath. Then when there is an acute flare-up, we can give topical or even sometimes systemic steroids. Always give a good antihistamine cover so that there is less itching, less scratching, less lesions on the body, because these lesions, they get secondarily infected if they are scratched or excoriated. And then in that case, you also have to give them topical or even sometimes systemic antibiotics. See, we give as a whole, we have to educate them that you have to keep your skin moisturized by using plenty of emollients. You should not use regular soap, but you can go for soap substitutes. Avoid excessive bathing, and you must use such cotton or pure clothes that do not irritate your skin. That is, you have to avoid all kinds of irritants that come into contact with your body from your environment, be it what you eat, what you wear, what you apply, or what you do for washing, right? Then excessive use of emollients before and after baths. Then in case of acute flare-ups, you can use, you might have to prescribe them topical or even systemic steroids. Then good antihistamine to prevent scratching and itching, and also for a good sleep at night, of course. And antibiotics in case of secondary infection. Then in case they are not getting any better with this advice, we might have to give them intensive topical treatment that may be in the form of different wraps, that may be wet wraps, or immunomodulatory creams can be given to avoid the side effects of steroids. These are tacrolimus or pimecrolimus. Then in case of any allergies to food, which is common in these patients, we can advise them allergy management or different avoidance of different kinds of food if they come to know exactly if they are causing any allergy. Some inhalant therapy may be required, and treatment of any kind of contact allergy should be taken into account. Then in extensive and chronic conditions and in many adults, if increased body surface areas are involved, they might need some kind of phototherapy that could be anything like UV, A, B, or even combination, that is PUVA, that is psoralen with UVA therapy. Then in some conditions, there may be a need of oral immunosuppressants, but that is in very rare or severe conditions. You might suggest them cyclosporine, azathioprine, or even oral corticosteroids. So this is all about the treatment of eczema. Are there any questions? Any questions regarding this? The 245 students listening to me, I assume that you are listening to me. My dear students, are there any questions regarding whatever we have done so far? That's good. So do I assume that you've understood whatever it was? No, that is, you did not get what I was teaching you? The reason for eczema in case of venous hypertension is stasis. That is, the blood is stagnant over there because of decreased venous return that leads to exudation sometimes. You must have learned in pathology that whenever there is stasis, especially in case of veins in the lower legs, there is exudation of fluid, serum, or other parts of the plasma, and that leads to edema. Edema might lead to thickening, scratching, or whenever there may be a vesiculation even, and that leads to scratching and itching. There may be purpura or hemosiderosis and changes like that. So this is a reason of development of eczema in patients with varicose veins. And there is a head of difference between rubella or measles and eczema. In rubella or measles, it's one-time infection in life. After that, you get lifelong immunity, and there is a typical rash that is seen on different parts of the body, and there is history of contact, there is history of fever in addition to itching. Differential diagnosis of eczema, there are so many differentials because it's been there for this according to your clinical morphology. Like in case of nummular eczema, discoid eczema, you can mistake it by taking it as tinea, that is fungal infection. Psoriasis could be any other infective cause, and when it's widespread, it's the most common cause leading to erythroderma. There is a long list of differentials of erythroderma. Why don't you suggest me one or two? Yes, it's a good question. How will we differentiate between discoid eczema and psoriasis? Especially in case of this, as if you recall from my lecture of psoriasis, you see that there are also discoid lesions, but there is lesions in case of psoriasis, they are raised. There is a typical salmon pink appearance with whitish scaling on top. And if you try to scratch the scale, there is positive Osbert's sign, that is pinpoint bleeding areas. This is not the case in eczema because the color is different in eczema and the lesions may be widespread, and upon scratching, usually there is no pinpoint bleeding as occurs in psoriasis. Good. Anything else? So today is Friday. Do not forget the Sunnah of Friday, that is whistle, reading of Surah Kahf, clipping of nails, then reciting a lot of scripture, application of good perfume, especially for males, and especially males, they have to go for Jummah prayers with all the COVID SOPs. And if there is any facility available, females also go, but they should not apply perfume. And do not forget to pray for yourself, your family, your teachers, and for all the Muslims all over the world. So today was your last lecture regarding dermatology. Any queries, any thing you want to know or learn more, you can always come to dermatology OPD room number 10 in OPD, and we are always there to help you. So goodbye till then, till when we meet again, I don't know when, and all the best for your life ahead, for your final year, and for the life after final year. Remember in prayers, and thank you so much. Allah Hafiz.